Inguinal hernia. Lichtenstein repair. Note: incision 2 c's above inguinal ligament. Open external oblique aponeurosis. Identify cord structures. Reduce hernia sac. Place polypropylene mesh over posterior wall. Secure mesh to inguinal ligament and conjoint tendon. Close in layers. Appendectomy. Open technique. Note: McBurney or Rocky Davis incision. Split external oblique, internal oblique, and transversus abdominis. Identify appendix. Ligate and divide mesoappendix. Double ligate appendiceal base. Remove appendix. Close in layers. Laparoscopic cholecystectomy technique. Note: 4-port technique. Umbilical 10 mm, epigastric 5 mm, right upper quadrant 5 mm, right flank 5 mm. Establish critical view of safety. Clip and divide cystic duct and artery. Dissect gallbladder from liver bed. Extract in bag. Inguinal hernia, totally extraperitoneal TEP repair. Note: 3 midline ports below umbilicus. Create preperitoneal space with balloon dissector. Identify landmarks: pubic bone, Cooper's ligament, inferior epigastric vessels. Reduce hernia sac. Place large mesh, 15x10 cm. Secure if needed. Robotic-assisted radical prostatectomy. Note: 5x6 port placement. Develop extraperitoneal space. Incise endopelvic fascia. Divide dorsal vein complex. Dissect seminal vesicles. Preserve neurovascular bundles if indicated. Divide urethra. Perform vesicourethral anastomosis. Check watertight closure. Facial fracture. Lefort classification and management. Note: Lefort E. Horizontal maxillary fracture. Lefort E2. Pyramidal fracture. Lefort E3. Craniofacial disjunction. Principles: reduce and fixate from top down. Use plates and screws. Ensure occlusal alignment. Consider intermaxillary fixati. Laparoscopic splenectomy technique. Note: right lateral decubitus position. 3-4 ports. Mobilize splenic flexure. Divide short gastric vessels. Identify and ligate splenic artery and vein at hilum. Dissect spleen from diaphragmatic attachments. Extract in bag. Check for accessory spleens. Pancreatic necrosectomy. Step-up approach. Note: start with percutaneous drainage. If inadequate, perform endoscopic transgastric necrosectomy. For persistent collections, consider minimally invasive retroperitoneal debridement. Open necrosectomy as last resort. Ensure adequate drainage. Mitral valve repair. Posterior leaflet prolapse. Note: median sternotomy. Cardiopulmonary bypass. Left atriotomy. Assess leaflets and chordae. Perform quadrangular resection of prolapsed segment. Sliding plasty if needed. Place annuloplasty ring. Check coaptation with saline test. Liver resection. Anatomical segmentectomy. Note: identify relevant portal pedicle and hepatic vein. Temporary inflow occlusion. Mark ischemic demarcation line. Transect liver parenchyma. CUSA. Clamp crush or energy device. Ligate pedicle intraparenchymally. Ensure hemostasis. Apply sealants. Tetralogy of Fallot repair. Note: median sternotomy. Cardiopulmonary bypass. Close VSD with patch. Resect RVOT obstruction. Enlarge pulmonary annulus if needed. Transannular patch. Repair atrial septal defect if present. Wean from bypass. Check residual gradient. Gastric cancer D2 lymphadenectomy. Note: remove stations 112A. Preserve pancreas if possible. Ligate left gastric artery at origin. Clear celiac axis. Common hepatic splenic artery nodes. Ensure complete clearance along greater and lesser curvatures. Minimum 16 nodes for staging. Carotid endarterectomy shunt placement. Note: indications: contralateral occlusion, recent stroke, poor collaterals. Insert shunt after arteriotomy. Ensure proper positioning. Secure with vessel loops. Maintain flow during plaque removal. Remove before closure. Check distal flow. Laparoscopic adrenalectomy. Transperitoneal approach. Note: lateral decubitus position. 3 to 4 ports. Mobilize colon. Identify adrenal vein early, right, IVC, left, renal vein. Clip and divide. Dissect glands circumferentially. Ensure hemostasis. Extract in bag. Check for accessory adrenal tissue. Endovascular aneurysm repair, EVAR. Note, bilateral femoral artery access. Advance main body over stiff wire. Deploy below renal arteries. Cannulate contralateral gate. Deploy contralateral limb. Extend if needed. Balloon mold. Check for endo leaks. Close access sites. Total knee arthroplasty. Alignment and balancing. Note, establish mechanical axis. Distal femoral cut perpendicular to mechanical axis. Proximal tibial cut with 5 diascience posterior slope. Balance flexion and extension gaps. Ensure equal medial and lateral gaps. Check patellar tracking. Confirm stability. Pancreaticoduodenectomy, uncinate process dissection. Note, mobilize duodenum, Cocker maneuver. Identify SMA at root of mesentery. Dissect retroperitoneal margin medial to uncinate. Ligate branches from SMA to uncinate. Use clamp cut tie technique or energy device. Ensure complete tumor clearance. Esophageal perforation. Management principles. Note, early diagnosis crucial. CT with oral contrast. NPO, broad spectrum antibiotics. PPI, primary repair if 24A, healthy tissue. Consider T-tube, exclusion, or esophagectomy for late presentation. Drain mediastinum, pleura. Nutritional support. Mastectomy, skin-sparing technique. Note, periareolar incision with lateral extension. Develop skin flaps to clavicle, sternum, inframammary fold, anterior axillary line. Preserve inframammary fold. Perform axillary dissection if indicated. Ensure hemostasis. Place drains. Close skin. Laparoscopic Nissen fund application, pearls and pitfalls. Note, ensure complete fundal mobilization. Preserve short gastric vessels if possible. Create floppy 360-degree wrap, 2-3 centimeters long. Use bougie to size wrap, 54-60 FR. Avoid over-tightening. Check for adequate intra-abdominal esophageal length. Liver transplantation. Recipient hepatectomy. Note, Mercedes incision. Mobilize liver. Isolate and divide structures at porta hepatis. Control suprahepatic and infrahepatic IVC. Remove diseased liver. Prepare CAVA for piggyback technique or perform Caval replacement. Achieve hemostasis. Breast reconstruction, diap flap. Note, mark perforators pre-op with CTA MRA. Raise flap on dominant perforators. Meticulous dissection of perforators through rectus muscle. Anastomose deep inferior epigastric vessels to internal mammary vessels. Shape flap, closed donor site. Abdominal aortic aneurysm, open repair. Note, midline laparotomy. Control aorta proximal and distal to aneurysm. Open aneurysm sac. Remove thrombus. Implant graft, tube or bifurcated. Oversue anastomoses. Close sac over graft. Check distal pulses. Close abdomen. Laparoscopic Rose NY gastric bypass. Note, create small gastric pouch 30 millimol. Measure roux limb E150 cm. Create gastrojejunostomy 25 mm circular stapler or linear stapler. Jejunostomy 50 cm from gastrojejunostomy. Close mesenteric defects. Check anastomoses for leaks. Principles of microvascular anastomosis. Note, use operating microscope. 9-0 or 10-0 nylon sutures. Ensure clean vessel ends. Place background material. Start with 2 stay sutures 120 degrees apart. Complete back wall, then front wall. Use interrupted or continuous technique. Check patency. Low anterior resection for rectal cancer. Note, medial to lateral mobilization. High ligation of inferior mesenteric vessels. Total mesorectal excision to pelvic floor. Transect rectum with linear stapler. Create colorectal anastomosis with circular stapler. Air leak test. Consider diverting ileosto. Open reduction internal fixation, ankle fracture. Note, lateral approach for fibula. Anatomic reduction, compress with lag screws. Apply neutralization plate for medial malleolus. Tension band or screws. Check syndesmosis stability. Repair deltoid if necessary. Confirm reduction fluoroscopically. Sleeve gastrectomy technique. Note, 5-port technique. Divide short gastric vessels. Create gastric tube over 3640 far bougie from 4 to 6 cm proximal to pylorus to angle of his. Use stapler with buttressing material. Check for leaks. Remove specimen in bag. Total thyroidectomy, parathyroid preservation. Note, identify parathyroids, usually 4 by location and color. Preserve blood supply from inferior thyroid artery branches. If devascularized, consider autotransplantation into sternocleidomastoid muscle. Check PTH levels post-op. Laparoscopic appendectomy, difficult cases. Note, for retrocecal, mobilize cecum. For perforated, careful dissection, copious irrigation. For base inflammation, consider partial cecectomy or ileocecectomy. Use endoloop or stapler for stump closure. Always extract in bag. Axillary lymph node dissection technique. Note, incision along hair-bearing area. Identify anatomical landmarks. Latissimus dorsi, pectoralis major, axillary vein. Preserve thoracodorsal and long thoracic nerves. Remove level I and II nodes. Ensure hemostasis, place drain. Thoracic esophagectomy, Ivor-Lewis technique. Note, 2-stage laparotomy and right thoracotomy. Mobilize stomach, create gastric tube. Mobilize esophagus, perform lymphadenectomy. Deliver gastric tube to chest. Create esophagogastric anastomosis. Place feeding jejunostomy. Whipple procedure, pancreatic anastomosis techniques. Note, options, pancreatico-jejunostomy, ductomucosa or invagination, or pancreatico-gastrostomy. Use fine, non-absorbable sutures. Ensure tension-free, watertight closure. Consider stenting duct in soft pancreas. Close mesenteric defects. Laparoscopic cholecystectomy. Critical view of safety. Note, dissect Cowlitz triangle. Clear fat and fibrous tissue from triangle's base. Identify 2 structures entering gallbladder, cystic duct and cystic artery. Visualize liver bed through triangle window. Confirm before clipping, cutting. Principles of fascial closure and laparotomy. Note, use monofilament suture, absorbable or non-absorbable. Continuous closure with large bites, 1 cm from edge, 1 cm apart. Maintain 4.1 suture to wound length ratio. Avoid excessive tension. Consider retention sutures in high-risk cases. Emergency cricothyroidotomy technique. Note, palpate cricothyroid membrane. Horizontal incision through skin and membrane. Insert tracheal hook, stabilize larynx. Dilate opening. Insert 6.0 ET tube or tracheostomy tube. Confirm placement with capnography. Secure tube. Carotid and arterectomy steps. Note, incision along anterior border of sternocleidomastoid. Control common, internal, external carotid arteries. Longitudinal arteriotomy. Remove plaque carefully. Consider shunt if needed. Close with patch angioplasty. Check flow with Doppler. Split thickness skin graft technique. Note, choose donor site, often thigh. Use dermatome set to 0.012-0.015 inches. Harvest graft. Expand if needed. Prepare recipient site. Ensure hemostasis. Apply graft. Secure with staples or sutures. Apply bolster dressing. Immobilize graft area. Laparoscopic ventral hernia repair, IPOM. Note, ports, umbilical, 10 mm, flanking, 5 mm. Perform adhesiolysis. Reduce hernia contents. Measure defect. Choose mesh with adequate overlap, 5 cm. Insert mesh. Secure with tacks, sutures. Close fascia if possible. Consider defect closure. End colostomy creation. Note, left lower quadrant site. Circular incision through skin, fascia. Mobilize descending colon. Create adequate fascial opening. Bring bowel through, ensuring no tension. Mature stoma by everting mucosa, suturing to skin. Apply stoma appliance. Sentinel lymph node biopsy in breast cancer. Note, inject radioisotope and blue dye. Incision in axillary fold. Identify blue-stained lymphatics. Use gamma probe to locate hot spots. Remove sentinel nodes, usually 1 to 3. Send for frozen section. Proceed to axillary dissection if positive. Laparoscopic appendectomy technique. Note, 3-port technique. Umbilical, 10 mm. Suprapubic, 5 mm. Left lower quadrant, 5 mm. Identify appendix. Divide mesoappendix with energy device. Apply endoloop to base. Divide appendix. Extract in specimen bag. Check hemostasis. Vascular anastomosis techniques. Note, end-to-end, evert edges use 6-0 or 7-0 non-absorbable suture. End to side, create fish mouth in recipient vessel. Use continuous or interrupted sutures. Ensure proper spacing. Avoid stenosis. Check patency after completion. Breast conserving surgery. Oncoplastic techniques. Note, level Y, glandular rearrangement, versus level 2, local flaps techniques. Ensure negative margins. Use volume displacement or replacement. Pre-op planning and marking crucial. Consider contralateral symmetrization. Two-team approach beneficial. Laparoscopic Nissen fund application technique. Note, 5-port technique. Mobilize fundus. Dissect hiatus and esophagus. Create 360-degree wrap around esophagus, 2 to 3 cm long. Use bougie to size wrap. Secure with non-absorbable sutures. Ensure floppy, tension-free wrap. Close hiatus if needed. Whipple procedure, key steps. Note, pancreatico-duodenectomy steps. 1. Coker maneuver. 2. Divide stomach duodenum. 3. Transect pancreatic neck. 4. Divide common bile duct. 5. Mobilize SMV portal vein. 6. Remove specimen. 7. Reconstruct pancreas, bile duct, gastro-duodenal anastomoses. Liver resection, segmental anatomy. Note, Queneau segments, Ive weight. Right lobe, VY. Left lobe, 2-4. Caudate lobe, I. Portal triad. Hepatic artery, portal vein, bile duct. Hepatic veins drain into IVC. Use inflow control. Pringle maneuver for bleeding. Modified radical mastectomy technique. Note, elliptical incision including nipple areola complex. Raise skin flaps. Dissect breast from pectoralis major. Perform axillary lymph node dissection, levels I and II. Preserve long thoracic and thoracodorsal nerves. Ensure hemostasis. Place drains. Thyroidectomy. Recurrent laryngeal nerve preservation. Note, identify nerve at inferior thyroid artery crossing or ligament of Berry. Use gentle dissection. Consider intraoperative nerve monitoring. Preserve parathyroid glands and their blood supply. Careful hemostasis is crucial. Hand-sewn bowel anastomosis. Note, 2-layer technique. Inner full-thickness continuous absorbable suture. Outer seromuscular interrupted silk sutures. Ensure good blood supply, no tension, and watertight closure. Check for leaks. Principles apply to small and large bowel.